Hello, I am Dr. Fred Southwick, one of the co-authors of the paper entitled Increasing Adherence to a Standardized Rounding Procedure in Two Hospital Inpatient Units, published in the Journal of Applied Behavioral Analysis. We would like to thank the graduate students, medical students, and hospitalists listed as co-authors who contributed to this important work. Our study addresses a major challenge in many quality improvement projects. How do we convince those caring for patients to change the way they work in order to improve patient care? First, let me introduce co-authors Nicole Gravina and Nila Radhakrishnan. The communication tool that we used was called TEMP, and this was to relate all of the key nursing and patient treatment plans at the bedside. T was for tubes, lines, and catheters. Are they needed? Should they be changed? E is for eating and exercise. Do they need PT? What are their dietary needs? And also excretion. Are they constipated? They need to have a bowel movement. And how does the patient sleep? And M is for monitoring. How frequently should vital signs be obtained? Does the patient need telemetry? Does the patient require daily blood drawing? And finally, P is for pain. Is the patient's pain under control and plan? Does the patient know the plan for the day? This simple mnemonic, we're able to cover all of the key elements that the patient and the bedside nurse need to know about. And we realized very quickly that when we presented it to the nurses and our physicians, that they nodded their heads and said, yes, I will perform it. But when we observed them, they did not. We recruited Nicole Gravina, who is a behavioral psychologist who has worked in industries to address individuals that resisted change, how to bring about that change. So Nicole, what were your recommendations of how we could actually implement effectively the TEMP bedside rounding system?
Well, the first thing that we did was we wanted to collect some baseline data. So we wanted to understand where we were currently so we could know how much improvement we needed to create. And then the second thing that we did was we did an assessment interview. And in that interview, we wanted to understand the barriers to completing that process. And so we recruited the physicians who were part of the process, nurse managers, and also charge nurses. And we asked them some questions related to what the barriers might be in the process. And what we learned was that first, some people didn't have clear information about what the expectations were. And so we realized we needed to clarify what the process was and what some of the expectations were, which we did through an email and also conversations with the providers. We also learned that people didn't know whether or not they were actually performing this in the way that they were supposed to. And so we figured out that we needed to add some feedback into the system. And we did that through some individual conversations right after the rounds. And we also did that by emailing graphs of performance that we had collected over time. And then finally, we learned that people needed to talk to each other about this process. And so we added in a 15-minute huddle on Fridays, which both Dr. Southwick and Dr. Radhakrishnan were a part of. And in the huddles, the nurses and physicians were able to talk to each other about how it was going. They could share. There were natural opportunities to provide each other feedback. We learned in the huddles that physicians were getting less nurse calls when the nurses were with them in the process and so on. And so each of these kind of small elements came together to help support the behavior change over time. And we spent quite a bit of time, in a few months that we spent supporting this change across time, and we were able to see some positive results.
Nicole, you had a group of observers, medical students and graduate students, observe the faithfulness of adherence to the rounding system. And you created scores and got a percent. And so what happened? You had a baseline intervention 1 and intervention 2. Can you describe the differences in the two interventions and the outcome?
Sure. So Each data point represents a physician who was observed for 5 rounds. And we actually did this because when we piloted, we found that when we followed them for the entire round, that 5 rounds was pretty similar to their score that they would get if we followed them for the entire round. And so in baseline, we were observing both units. The first unit's on the top panel and the second unit is on the bottom panel. And this is their percentage of adherence. And then near the end of baseline, we did that assessment interview where we tried to work collaboratively with the providers to identify some solutions that would be supportive for them to help encourage adherence. And in the first intervention, we wanted to choose intervention procedures that were the least effortful on our part because, people are busy and we want to choose interventions that don't require as much work. And so our first intervention was an email to the providers that outlined what the expectations were and clarified some information for them and reminded them to follow the TEMPS procedure before they started their 7-day shift. And we also met with the nurses and reminded them about the TEMPS process and reminded them at the start of their shift. And we included the huddle in this intervention, which was just 15 minutes once a week to discuss the rounding process. After we implemented this intervention, we saw some improvements over time. You'll see an increasing trend in Unit 1 that dropped off. And what happened at that point was that they got an influx of new providers as it started to drop off. And so we had a new group that we needed to train up. So in intervention 2, that's where we added the more intensive feedback component. So after our observers observed, they asked the provider and the nurse if they'd like to know how they did. And then they provided some feedback, told them what they did well, and 1 or 2 things that they could try to improve in the future. Then we also emailed the nurse manager of each unit a graph of how their unit was doing so that they had an overall idea of adherence level, and they could also have individual conversations with their team. And we gave them 1 suggestion of things that they could focus on for the week based on the data that we had collected. And so you'll see after we added the more intensive feedback intervention, we saw further improvements.
Dr. Nila Radhakrishnan is the chief of hospitalist medicine, the division where we implemented this change. So, Dr. Radhakrishnan, what did you see happen?
Well, what I really liked about the program that Dr. Gravina and you and others helped implement is it was about support. It was about how can we support the adherence to the checklist, the behavior we want. When that was achieved, we saw that there was tremendous teamwork with the nurses, the physicians, the patients were involved. And the beauty of all of this meant that there was better communication. So it goes back to the George Bernard Shaw saying, the trouble with communication is the illusion that it's happened. In this setting, we realized it did happen and there was adherence. And we're actually looking into some data points now. And I will tell you that the preliminary data shows that there is improvement in patient satisfaction and other metrics. So I think the novel part of this project is supporting the team with these behavioral techniques to be able to do the right thing and generate the outcomes we want.